very much for the opportunity to speak. Hospital administrators and leaders right now are as stressed as everybody else, maybe more so because we're trying to take care of our staff, and that makes this very, very difficult. So we're going to spend a few minutes here, and we're going to get started on the slides and tell you what we've done here and what's working out really, really well for us. So Sparrow's in Lansing, Michigan. It's the capital of Michigan. I am literally less than a mile away from the capital, and I've got the governor as a routine visitor here. We are the second busiest trauma center in the state behind so we're busy all the time. It's interesting. When I came here, I did not appreciate that Sparrow had a couple of things that were extraordinary. One was a lab that is one of the top 20 in the country, and a trauma program that is really, really very, very good and very, very busy. So 5 community hospitals. We've got about 8,000 employees in the entire health system, 5,000 employees here at Sparrow with about 500 members of the medical staff. So we'll go to the next slide there, Steve. So, we talk about conduct an effective briefing and how important that is. When I was in the middle of Hurricane Harvey, where I got to spend a lot of time, this became really something very critical. And so we've taken the lessons from Harvey and made them here. What we do is a series of things that are standard work for us every single day, and they've been standard work for us now for well over a month. We've been preparing for a surge here since sometime in late February is when we first started having, we stood up our command center, we got ready, we started to sequester supplies, put our processes in place. So we do lots of things here. We'll talk about utilize team problem solving. We do that. We've got a couple of teams that we'll talk for a minute about. An innovation team, which is extraordinary, and a clinical leadership team, which is made up of ER docs, infectious disease, internal medicine, intensive care, and that clinical leadership team is really critical. They're tied right into our chief medical informatics officer as well, and so that's worked out extremely well for us. We do a lot of closed loop communication, a ton. We don't want to leave things out there hanging, so we'll spend more time talking about education because I think that's really where we do a lot. And then at the end of every session, we debrief, and I mean that is a religious thing. At the end of every session, we debrief. We have a command center meeting. We talk about it briefly afterwards. What worked well? What didn't work well? What are you going to do? And then we follow up, and follow-up makes, of course, a culture of accountability really work, and that's led us mentioning things here. So let's talk about our briefings. We have, out of the command center, we started off because there was so much changing information. We were sending stuff out it seemed like a lot, like 7-8 times a day. The CDC would change. We'd hear something from somebody else, and too much information. So we cleaned that up, really quickly identified that's too much. And so we have a 10 a.m. memo, a 3 p.m. memo that comes out of the command center, and we do a 1 p.m. phone call we'll talk about in a second, and we do a president's memo. The memos that come out talk about what's going on for the day, what do we want to accomplish, what's our goal. So we'll talk about, we've got a supply goal, we've got a clinical care goal, we've got a goal in the emergency department, this is what we want to accomplish for the day. We talk about what we did in the last 24 hours, what has happened, what's changed, what information have we gotten, what has the FDA said about this, what has the CDC come out and said, what are we hearing from our state government, what's the newest governor's edict, the newest governor's executive order, and how do we respond to that? Because some of her executive orders we've had 12 hours to respond to. What's going on in the community, things like that. So we publish a lot of data. And then we decided early on that with all of the changes happening, unless it was a life or death change, we now have standard work. Every change occurs at 9 p.m. at night. Why does it occur at 9 p.m.? Because if the decisions are made on day shift, you can't get to your day shift staff and get them ready for it quickly. So you put it out there. It gives you time to get ready for that 7 p.m. shift change, which most of our nurses are on. And then we knock it out in the huddles. And then it gives the day shift knows about it when they're going home. Night shift hears about it at the huddle. We drop it in place at 9. The reality is most things drop in place at 7:30, but this gives people time to feel like they can get around it. So that has been a real key win for us because we don't just make a change and throw it out there. The changes go out, they get vetted, and then 9 p.m. at night you drop the hammer, and it gives everybody lots of time. We've gotten lots of positive feedback from the staff about that. There's a third memo that goes out every single day, but its time frame is based off of when I have time to write. We talk about, in the first two memos, all the details of the work, but that third memo, that president's memo, we've been doing that since I came here back a year ago, and we got an immediate threat. We got 10 immediate threats to life from the Joint Commission, and we had a preliminary denial of accreditation, and we had to get out of it, so we started writing memos. This memo is about behavior, and it's about morale. This memo talks about what have we seen, what's working well. So we've talked about social distancing. We've talked about social media, and don't look at Facebook as a scientific source of anything. That memo is critical. We get extraordinarily good feedback on these three memos, and that's our communication. So we'll go to the next one. This we started about a week ago. We know that not everybody has a chance to read their emails, and not everybody's got a chance to do that. And so how could we do something in a 15-minute window on a daily basis and open it up broadly that people could dial into, and then we could record and they could listen to later, and it's about to come out as a podcast here for our staff. And so we open up the phone lines to 5,000 people. Obviously, night shift doesn't get this until they come in, but we do the same standard work every time. We do COVID by the numbers. So we talk about the number of tests we've run, the number that are positive, the number that are negative, the number that are pending. We talk about our patient data. How many patients have we got in the hospital? How many are in intensive care? How many are vented? We talk every day about the number of caregivers we've had turn positive. We put that information out there first. When we got our first caregiver positive, everybody knew it. When we got our 9th caregiver positive, everybody knew it. And these obviously are not all occurring inside the hospital. It's some are community acquired, but we've got a couple we think probably did happen inside the hospital, because at the very beginning, we were not doing things well. We didn't don and doff well. We didn't do PPE well. So we talked about that. So this COVID-19 by the numbers gives all the data, and it's unvarnished. The first death we had from COVID, we talked about. The first discharge, we talked about. We then give the actual days on hand for supplies. We tell everybody, this is what our gown rate is, this is our goggles, this is what we're doing with N95s, this is what we're doing with simple mask. Everybody gets that data every day. It's based off our current burn rate. And if you talk to the staff today, well, about what a burn rate is or how many days supply they have, the first question they'll ask you is, well, what's our burn rate? Because we talk about it and our staff get it and they're engaged and they're helping. Then we go through caregiver operations. So we talk about what's going on here in the hospital that's really important. And like, we're limiting our traffic flow in the hospital. We're not crossing paths with, you've got a COVID patient and you don't have a COVID patient. Those don't cross paths anymore. We talk about critical questions that go in. We have a website. It's COVID-19 questions for caregivers. They can email this website, this email address, and we go through it every day, and we answer emails. But what we do is we take the top questions out of there, and I talk to them at that 1 o'clock call every day. That 1 o'clock call, by the way, is 7 days a week. We do it on Saturday. We do it on Sunday. We never skip. The other person who helps me out with this is my chief nursing officer. And by the way, she's been a chief nursing officer for almost 3 weeks. So it's trial by fire, and she's doing great. We talk about concerns on the website, and then we load it up daily. So let's do the next one. We talk about team problem solving and how important that is. So we have an innovation team, and our innovation team is made up of a pharmacist, a pathologist who's an MD, JD, and somebody from operations, somebody from the supply side, and then we have a project manager. And the way this works is we've reached out to the staff, and we said, if you can find something that will help us, help us. So people have given us ideas around N95s. They've given us ideas around face shields. They've given us ideas around how to prevent pressure ulcers from wearing a mask. In my hospital, we wear a mask 24 hours a day. Every single person, all of our patients must have a mask on. If they can't tolerate a mask, we have a conversation with them about what can we do to get you to tolerate a mask. We're trying, it's a simple mask. We're trying to decrease the viral load. Today, every caregiver in our hospital goes to an N95. If you're in the hospital and patient care area, you're wearing N95, COVID or not, because there's too much information out there now about this being potentially airborne, and we're seeing things just make us feel like we've got to do it. So what's come out of the innovation thing? What's come out of it is that there are 4 ways to reprocess N95s. One of them with Battelle. We've been on the Battelle pathway now for 3.5, 4 weeks, but we also looked at UV light from Nebraska, and we've done something creative here that we're trying to get FDA approval for. If you bake your N95 for 30 minutes at 158 degrees, virus is dead, gone and done. And we have an industrial bakery here with the extension service from Michigan State University, and Michigan State is applying now for an FDA emergency use. We've validated that the masks are intact, and we validated with the virologist that this virus can't survive at that heat for that level. So we've done the two things, so we got a process worked out for that. So the innovation team also found a way to make face shields. We have 30 people from the community that are making face shields. They can make 1,500 per week. That transitioned into a laser etching company here in Lansing who figured out that they could crank out thousands, and they've got the raw materials. So we've got lots of things going on here in terms of we feel better about our PPE than most places because we knew early on, and we're working on vaporized hydrogen peroxide. We knew early on that if we could heat these things, it worked. And quite frankly, here's the other kicker. We knew early on that if I sat an N95 on a shelf in a dry environment and after it was clean, I sat it there for a period of 3 days, the virus would die. This virus does not survive outside the body. So we emailed the University of Nebraska. These are the world-renowned experts and said, if we just leave this equipment alone for 4 days, can we reuse it? The virus dies. And we got a response within 24 hours that said, that sounds completely reasonable to us. So we then contacted the inventor of the N95. And we said the same thing to him. Can the mask tolerate baking? Oh, that'd be a great idea. Can the mask tolerate this? Yes. And we said, well, what about leaving the N95 to sit? And he said, well, if you have 4 masks. And he gave us a process. So we feel better about our N95s because, quite frankly, we know we can reprocess them. You can reprocess your N95 and your STERRAD in your hospital. Information came out 2 days ago about that. You can reprocess in a STERRAD. STERRAD will give it 2 more uses. So now you extended your life of your N95 from 1 use to 3. So if you had 80,000 on hand, you just got 240,000 on hand. And so we feel pretty good about this. We're going to struggle with gowns a little bit, but one of our local garbage bag manufacturers has changed their production line to go from garbage bags to gowns. They're not form-fitting. They're not attractive, but you can throw water on them and it won't go through. So that works. So we take all of the innovations we've gotten, and we've got hundreds of them, and we rank order them based off of the effort to get it done and the bang for the buck. So we have an effort impact matrix that our project guys do, and then they put a thing around it. They put a rank ordering around it. So we debrief every day after every meeting. I'll get debriefed on this phone call, as a matter of fact, and we'll talk about what went well, what we should improve, and how specifically we need to make that happen. We make time for it. It doesn't take very long, but it's critical. We do it in our operating rooms. We do it after our laboring patients give birth. We do it here in the hospital all the time. We try and do it in the emergency department. Sometimes these are 2 minutes, but after meetings in the command center, they tend to be closer to 5. It's helped us reshape and have better meetings, and it's helped us get better communication, and it's really helped us understand what do people need in a very dynamic environment. No one here, except for me and my vice president of operations, who I stole from Houston, have ever been through a disaster. And so this is new territory. And so these are the kind of things we've taught people. And I will tell you that in a matter of a couple of weeks, my team went from really struggling, and we were doing a lot of coaching all the time, to I was out of the hospital yesterday for about 5.5 hours, and I didn't even dial in, didn't care, because that team now runs this thing like nothing you've ever seen. And our system-wide leadership team has learned that for all of our hospitals, if they've got a problem, call the command center. I've got the best and brightest people who've been given the freedom to be successful, and we tell everybody, make a decision one time. You don't make decisions 6 times. Make a decision once and move forward. If you need to tweak it later on, but make a decision and get it done. And that sort of sense of, I've got the freedom and I have a sense of urgency and I know that I'm responsible, I'm accountable for it, has really been fabulous here, and it's worked out well. So we talk about all these things. This is the other thing that I think is really critical for us. Some of the hospital partners here are not necessarily easy to deal with. They have corporate entities that are far, far away in a land far, far away. They're locally run, but they're managed really in a corporate office. And so we haven't had great relationships with them historically. Well, we've changed that. And so we've reached out and we've gotten commonality. So the commonality things around, we can help you with reprocessing. We can help you with how we manage nursing home patients. We can help you manage ethical issues. So we're on the same page with them about our ethical issues. One of the things that has been extremely helpful here, and it's kept our volume down, really helped our volume a lot, is that about 4 weeks ago when we first started, we reached out to the long-term care homes, the nursing homes, and had a dialogue with their administrators about what can you keep in your facility and what do you need to tell us when you're bringing a patient to us. So no patient comes in, for instance, without a medical power of attorney or a durable power of attorney. Nobody comes in without a code status. Nobody comes in without an end-of-life care plan. And those are very clear. And, we've really had a lot of dialogue around, do not resuscitate doesn't mean do not treat. You can do that, but you can also treat in a long-term care facility. So we've tried to manage really aggressively on the front end the volume coming in from our long-term care facilities, understanding that when they need us, and we're going to respond. However, what can we do to help you keep your patients in place? And how does that look? How does that work out for us? And so we've done a really good job of that, and we've developed those protocols. This has been very helpful for us as a hospital system because I think instead of seeing what we've seen other places where the nursing homes dump out, our nursing homes are really appropriately managing. So we talk to all the medical directors at all of those long-term care facilities, talk to administrators, talk to long-term care. Worked out really well so far. That's a lot, sorry. I probably went over.